everybody. So yesterday we talked a lot about how to bring in the nails, and so now I want to share with you a little bit some considerations on the bone regenerate and on the rate of distraction and how to monitor it. So I think if we think about the bone regenerate, we really have to go back to what we already know, and I think you've seen this slide over and over that keeps us to remind that it is still Elisarov lengthening we are doing here. And so all his thoughts on the regenerate are still very valid. So we know that the level of the osteogenic activity within the distraction zone is really depending on two things. So one is the stability, and the other is the amount of damage to the bone marrow and the periosteum when you do your osteotomy and when you insert the nail. So this is something to really remember. So we always try to drill the osteotomy very slowly, use very sharp drills, change the drills if it's sclerotic, and wait a little bit to cool down again, and then make a cold osteotomy with the chisel. So the other thing we know from a study by Fishkron and co-workers and from our experience is that generally the femur is doing better than the tibia regarding the regenerate. Younger people tend to do better than more older people. Osteotomies in the metaphysis heal nicer than those in the diaphysis. And we do know that the distraction consolidation index is not a constant, which means like 4 centimeters are not double the time to bone healing than 2 centimeters. So the more you lengthen, the shorter the bone regenerate takes relatively. So what about the rate of distraction? Studies from Elisarov showed that the elongation by 1 millimeter per day in 4 equal increments leads to the most favorable results, and this is something we always used in the Elisarov lengthening, which was not so easy to do with the TSF lengthening, and now we can go back to this and do it exactly like this. It also has been challenged. The question has been asked, if you do it more continuously, if you do it in smaller steps, will there be a better bone healing? And so in fact, it was shown that it doesn't improve the bone healing, so it seems that it's still valid. 4 times a quarter of a millimeter is the best way to get good bone healing. So about the latency of distraction, we usually wait about 5 to 7 days before we start to distract, depending on the age of the patient, depending on the underlying problem. If you have like a post-traumatic patient with a lot of vascular clips somewhere, you definitely want to wait longer. If you have a smoker, you want to wait longer. If you have small kids, 5 days are really fine. And we start our distraction with 1 millimeter per day for the femur, but for the tibia, so I like to start with 0.75 millimeters per day, because I know that we know that it's not healing so nicely. Now, nevertheless, in the course of distraction, we really need to monitor the callus, and we have to assess the regenerate. So we take an X-ray like every week or every second week at least. You want to have standardized X-rays. Again, you want to include a magnification marker. You want to be able to measure that the amount of distraction is what you want from your nail, that your nail is doing what it should, that you know that the patient is using the ERC in the right way, that he's placing it on the right spot. So this should match up, like the amount that the ERC shows you and the amount you see in the X-ray should match up. And then you want to assess the regenerate. And you can see like a normotrophic regenerate, you can see an atrophic regenerate, sometimes you see a hypertrophic regenerate, and of course, we love this one the most. You need to be careful. Sometimes in the beginning it looks very nice because there are all these reamings. And you think, it's a lot of bone, that's great. But the reamings, then they can really be reabsorbed and they can vanish, so suddenly it starts to look not so nice than before. So this is mostly when the reamings are absorbed again. So what can you do if it doesn't look so nice? You can slow down. So you can go to 0.25 3 times. You can go down to 2 times, even 1 time. You might want to go back and forth if it's really bad. If you have questionable compliance, or if you think there's still like kind of too much lengthening going on, you can reprogram the ERC to program a maximum daily distraction. Nevertheless, on the other hand, if you have hypertrophic callus or in very young patients, and if you're afraid of premature consolidation, you want to speed up, then you have to reprogram, because usually, or in many programs, it's like 1 millimeter per day is the maximum distraction, so you have to change this if you want your patient to go faster. So let me show you a couple of things we found out. So in the very first generation of the precise, in the P1, we had like one case of backtracking of the nail with too much loading through the patient. And you know, it really went from this to this, and we were quite shocked. This was like our first like 10 patients, so we told the patient to lengthen again and to really distract it out, and we were looking if it's still lengthening. So we did like, I think like 2 or 3 millimeters acutely, and then we checked it like in the x-ray. But nevertheless, because we did this and we re-lengthened, in the end we had a very atrophic situation and a very delayed bone healing. So we did some bone grafting, and we just like added a plate for additional stabilization, and it healed quite nicely. But this is something we've never seen it with the P2 nail, so this seems there's been a really great change. So this was another surgery with a pretty bad bone consolidation, and there are like two important factors for this. So one important factor is if you look at the diameter, the nail is quite small, and there might be a little bit some instability. The other thing is, if you look very closely, I don't know if you can see it, you can see there are like small things falling off the nail here, and you can see it. So this was a so-called crown fracture, which was also a problem, which is no longer with the current version of the nail, but it made the nail less stable, because it wasn't so stable rotationally. So remember the first slide, less stability, no good bone healing. So you can see it, that's the problem. So nevertheless, it did heal, but it took a really long time, and it didn't heal very nicely. So stability is really the key. So if you don't see callus, like in this case, this was an acute correction in the tibia, and actually the problem was that because of the core of the deformity, I needed to do the osteotomy quite low, and this is an area with a very bad blood supply, because it's kind of proximal to the diaphysis and distal to the metaphysis. It's like the area where there is the least blood supply in the bone. So you can see there's really like nothing coming here. But you know, I really slowed down. I slowed down to 0.5 to 0.3 per day. So very little distraction. In the end, it was not a lot of bone. Took a long time. It formed. It came. In the front, there is still not a good bone formation. So this is something we would have been very afraid with the external fixator, because you know, as long as it looks like this, it's difficult to remove the frame, because you're afraid of refracture. Now with the nail, it's not such a topic, because this patient is like doing full weight bearing since, I think, 4 months after the surgery. 3 months after the surgery, maybe. Yeah. So if you see this, it's more like a nuance, but it's not like a problem, because you can simply sit it out and wait. And if it takes 2 years, it takes 2 years. Doesn't matter. The patient is doing full weight bearing and is not really suffering from this situation. Hypertrophic callus we don't see so often, but we do. So this is a very young patient. So this patient was like 9 years old, and you can see he was really walking on the nail. And you can see at the end of distraction, which was, so after 9 weeks, he was nearly fully consolidated. And about 4.5 months afterwards, he was fully consolidated. And so, of course, weight bearing, young age is something that really fires up your callus formation. But you can get hypertrophic callus also in not so young patients. So this is definitely a quite old patient. And you can see maybe stability, 4 centimeters. These are still 4 centimeters, but maybe it's not so stable. It's a big canal. It's not such a big nail. So this is maybe again a factor that kind of triggered the hypertrophic callus in this 74-year-old patient. But it healed very nicely, and he was full weight bearing after 2 months for 2 centimeters of lengthening. So in summary, I think it's very important to think about these things when you do the osteotomy, when you start distraction, when you monitor the callus. you really want to create the optimum conditions for the callus, and you want to follow it. So if you see that no bone is forming, just try to solve it before you're at the end of your distraction and you're facing a big black gap. Thank you.